my name is Angela Chandy, and today we will be reviewing the revisions of therapeutic monitoring of vancomycin for serious MRSA infections. And these actually came out just a few months ago in June of 2020. Objectives for today: we will be reviewing the pharmacology of vancomycin. We will then review previous vancomycin therapeutic monitoring in serious MRSA infections. We will then analyze relevant, revised, current vancomycin therapeutic monitoring in adults, and we will do the same for pediatric and neonatals as well. A little bit of background: we have vancomycin is a glycopeptide antibiotic that is bactericidal. It inhibits cell wall synthesis and is typically used in severe gram-positive infections, particularly, of course, in MRSA. As we know, vancomycin has a narrow therapeutic index. You typically see an AUC/MIC of greater than or equal to 400. Troughs are typically obtained in steady state, which occur after the third or fourth dose. And then nephrotoxicity is something you always want to look out for. You have an AUC/MIC of greater than 700 to 1300, or when the trough is sustained at greater than 20. So of course we want to minimize both those things. Additional risk factors that might also occur is whenever you have an increased body weight, or if they are along with other medications such as loop diuretics, aminoglycosides, or having contrast dye. A little bit of background on monitoring is the ratio of AUC/MIC we usually see is greater than or equal to 400 as a primary PK/PD predictor of vancomycin activity. The trough goal is usually 15 to 20 in this population for life-threatening infections or poor penetrations of sites for these disease states as mentioned below. However, there's actually a lot of gaps in knowledge due to insufficient data, especially in pediatric, neonatals, and morbidly obese. And therefore, there's a need for the revision to evaluate current data and controversies with vancomycin dosing, their concentration, monitoring for serious MRSA infections. Now, know that this actually does not include MSSA strains or serious and basic non-bacteremic skin and skin structures or UTIs. And so you want to make sure you use caution with all of these. For the methods, a panel of physicians, pharmacists, and a clinical pharmacologist actually peer-reviewed studies published from 1958 to 2019 and looked at the quality of evidence. They used PubMed and Embase, and they looked for those terms as listed below, such as vancomycin, PK, PD, etc. But a limitation of the review was that there was few published randomized clinical trials of vancomycin dosing and monitoring, and actually the majority were retrospective PK/PD studies. For targets, we have the AUC/MIC greater than or equal to 400 as the currently accepted critical PK/PD index. However, we've actually seen that studies have shown bactericidal activities will occur when that ratio is greater than or equal to 400. But when it's less than 400, there's actually an increase in MRSA resistance. One of the studies even noted that there's an increase in vancomycin treatment failure with MRSA infective endocarditis whenever that target is actually less than or equal to 600. Calculating AUC, which is why people usually use the troughs, is very cumbersome, and so they actually recommended using this Bayesian software program to use. But you want to make sure you want to use trough and peak and not just trough, but we'll get into that a little bit later. We currently use a trough concentration as a surrogate to estimate the AUC over a 24-hour period of time because of how hard it is difficult to estimate that AUC over that 24-hour period of time, because this requires a collection of multiple vancomycin serum concentrations during the same intervals, and softwares might not be readily available. But a problem with using trough is it's actually just a single exposure. Though this might be practical, it's only one specific minimum of daily AUC, and this might be insufficient when you're guiding dosing in all of your patients. It's actually shown that a wide range of AUC from different dosing regimens can actually yield the same trough values. So that's one thing we have to take into account. Versus AUC is actually an average concentration during that time period, and so it's more of a big picture versus just a single snapshot. For vancomycin susceptibility, the MIC measurement that you see, like the AUC over MIC, that measurement is actually sometimes imprecise and has a high degree of variability. Sometimes it's not even available during the first 72 hours, and that's why you might even hear me neglect saying it. Because based on the studies, meta-analyses nationally and within the United States, we've actually seen that the vancomycin MIC has remained constant over over time to equal to or be less than 1. And so you haven't seen any evidence of MIC creep, which is very good considering all the resistant problems that we've had. Which leads me to the first recommendation we have of today, is basically based on the current MIC values, we can assume for empiric dosing that the MIC value will be 1. If MIC is actually greater than 1, the probability of achieving that target of greater than 400 is low, and it's not worth doing those higher doses because it might increase the chance of toxicity, and therefore you want to use clinical judgment during that. And whenever MIC is less than 1, they actually don't recommend increasing the dose. You've heard me mention this Bayesian-derived AUC monitoring. Basically what this is a fancy software that's included all of this well-developed vancomycin population PK modeling with concentrations, and it's calculated optimal dosing regimens. An advantage of this is that it actually is able to collect within 24 to 48 hours instead of using steady state. So you're able to actually make changes earlier compared to waiting till later for that steady state. It's able to deal with dynamic changes and optimize future effects as well, and deal with real life situations. But of course, there's always limitations that can occur. This is not exactly, applicable maybe to the obese population or pediatrics. So that's something we have to keep in mind. This leads me to the next recommendation of saying that monitoring may begin within 24 to 48 hours. We want to do that as soon as possible. Any delay can, of course, cause more problems, and we don't want that. Vancomycin in pediatric patients. Vancomycin was actually the drug of choice for invasive MRSA infections in children. Virtually, there's no prospectively collected data on outcomes of MRSA infections in newborns, infants, or children. We all know that newborns actually have an immature renal elimination and a relatively increase in volume of distribution of body weight. They're continually maturing their glomerular filtration, and therefore developmental PK from neonates all the way to adolescents actually provides a lot of challenges in the generalization of vancomycin dosing. Recent retrospective studies with MRSA strains in children treated with vancomycin at a trough of greater than 15 were not associated with improved outcomes and actually have an increase in AKI. There's an absence of prospective comparative outcomes in children with serious MRSA infections, and therefore we need to design those trials to see and to make sure that we want to achieve the AUC of 400 to 600. The AUC/MIC target of 400 is actually more achievable in children than adults and correlates to a lower trough concentration of 7 to 10 compared to 15 to 20 in the adult population for this disease state. Current vancomycin dosing of 45 to 60 mg per kg per day in divided doses may be insufficient to achieve currently recommended targets for those ranges of AUC from 400 to 600, and so they're proposing using higher doses of 60 to 80 mg per kg per day every 6 hours, which you want to take into account for the increased clearance in pediatrics, and this may be needed to achieve targets for MRSA strains. In a Bayesian population-based PK model, they actually saw doing 80 mg per kg per day resulted in a median AUC of 675 and a trough of 16. And there's also, whenever you're 12 years and older, receiving the 60 to 70 mg per kg per day every 6 hours, you can see that the AUC is 400 and the trough is 8 to 9. Other studies are also saying that there's a need for higher doses for 60 to 80 mg per kg per day, and this of course depends on the age and the renal function as listed in those 3 studies below. Vancomycin is renally eliminated and requires dosage adjustments in children with acute or chronic renal insufficiency. In a Bayesian model, we see that the vancomycin at 45 mg per kg per day who had renal impairment achieved an AUC similar to those receiving 60 mg per kg per day in patients with normal renal function. 87% of those children that had the initial renal impairment actually had improvement within the first 5 days of therapy. And therefore, that means you probably need to assess and readjust their medication as well. Vancomycin clearance does not always correlate well with renal function, especially in children that are acutely ill in the ICU and all of the renal dysfunction that occurs as well. This leads me to the recommendation that dosing adjustments may need to occur with patients with renal insufficiency and those receiving concurrent nephrotoxic therapy. Of course, we want to make sure we have subsequent adjustments as well, especially maybe within those 5 days of therapy, they might be necessary to adjust as that renal function is changing. Loading doses may be considered in critically ill adults in order to achieve that steady state quicker, but preliminary pediatric data of doing a loading dose of 30 mg per kg might actually be lost if the maintenance dose following it is insufficient in order to provide that adequate ongoing exposure, and therefore requires longer investigations, which is exactly what this recommendation says as well, but we still need further studies. A study shows that troughs greater than or equal to 15 actually increases the risk of AKI odds ratio by 2.7-fold, and it's also correlated with staying in the ICU. We see in a published uncovered association between trough levels greater than 15 to 20 and AKI in the pediatric population. In a Bayesian estimation, we see that after adjusting for ICU stay and using nephrotoxic drugs at the same time, an AUC greater than or equal to 800 and a trough greater than or equal to 15 were independently associated with greater than 2.5-fold increase of AKI risk, which leads us to our recommendation that we want to make sure that our thresholds for AUC is less than 800 and our troughs are less than 15 to minimize that AKI. This population-based PK analysis on patients aged 3 months and older basically is saying that there's a better estimation of using both trough and peak values instead of just using one or the other, and this can help improve prediction of future AUC exposure. And so despite limited studies, it actually says that it supports using AUC-guided therapeutic monitoring similarly to adults, and this will help predict toxicity with AKI because we want to make sure that since the clearances are different with children and pediatrics, we want to make sure that we're doing all that we can. And there's also difference in infection sites, such as having a more common endocarditis being with MRSA in adults, and then we might even have osteomyelitis with children, and you have to consider doing like the bone concentration amount as well. This leads me to the recommendation that basically just says using AUC guided therapeutic monitoring, using that Bayesian estimation will be good for all groups, including pediatrics. We want to make sure we use both trough and peak instead of one or the other, and so that will be helpful. And you want to make sure you're always monitoring our serum concentrations and renal functions, especially in this population. As we know, vancomycin is a large hydrophilic glycopeptide. Dosing is based on total body weight for both obese and non-obese, but we've seen that serum concentrations have been documented to be a little bit higher in that overweight/obese population, but there's no increase in AKI. An alternative method that can be considered to use is BSA, though height might not always be available and people might not be as familiar with it as well. Using a Bayesian estimation, it actually says when using vancomycin of 60 mg per kg per day, fewer obese kids that were less than 12 compared to those that were greater than 12 achieved an AUC of /MIC of greater than or equal to 400. Leads to the recommendation that obese children are likely to have vancomycin exposure that may be statistically greater than those in normal weight children. These differences are not known to be of sufficient clinical importance, and therefore obese children less than 12 compared to those greater than or equal to 12 may require a higher mg per kg per dose. Therapeutic monitoring is likely to be important in obese children because you want to make sure you're not going to cause toxicities, and therefore a loading dose of 20 mg per kg by total body weight is recommended in obese children, regardless of age. As renal function increases during the first several weeks of life, we must consider that during our vancomycin monitoring, a population-based PK model showed serum creatinine-based dosing predicted trough concentration with the smallest variability in both term and preterm, but there is no consensus on optimal dosing. A Bayesian estimation simulation demonstrated that trough concentrations ranging from 7 to 11 were highly predictive of that AUC goal we're trying to meet of greater than or equal to 400. So that's good, showing that the trough level can be a little bit lower. Vancomycin associated AKI is also pretty low in the neonatal population. This leads to the dose recommendation for neonates of being 10 to 20 mg per kg every 8 to 48 hours for those up to 3 months. And you want to make sure you're getting an AUC of 400 using the Bayesian estimation and AUC guided therapy monitoring. And here's a summary of the recommendations. studies are needed to support vancomycin use in special populations for other pathogens, and there's also a need for a dosing algorithm. In conclusion, to optimize vancomycin use for the treatment of serious MRSA infections, we want an AUC/MIC of 400 to 600. AUC should be used to therapeutically monitor and be using both trough and peak along with basin approaches as well. We must properly educate and update everyone on all these changes because it's a pretty big deal. And here are all my references. Thank you so much for your time.